Let's talk a little bit about the remaining challenges. Now, obviously, one of the biggest remaining challenges is that many people worldwide die from viral hepatitis. And you can see how from 1990 to 2013, and this summarizes the leading causes of mortality, how it moved from position 10 to 7. So the amount of people dying from viral hepatitis actually has increased. Probably 1.4 million are dying every year. So clearly, dealing with viral hepatitis, if you look at the death toll these diseases take, I think is still appropriate. So what are potential areas of interest? And I think this is sort of a nice closing talk in the sense of it does cover a lot of things which have been addressed here at the meeting. So let me say a little bit about hepatitis A and B vaccination, harm reduction, interventions, cascade of care, increased awareness for possibility of having viral hepatitis and improved diagnostics, touch upon HPV cure, new treatment options for hepatitis delta and hepatitis C vaccine. At this meeting, you had two presentations of recent outbreaks of hepatitis A. These are two rapid communications from this year. Also, reporting back from acute hepatitis C outbreaks in England and in the Netherlands. An interesting thing, it happened during the Europride. So Europride is sort of a bigger gay pride fest, which includes, all European countries. There's going to be the World Pride in Madrid next week, and so I hope we're not going to see another outbreak report coming from that event, but telling us that obviously hepatitis A vaccination, which is very easy to perform, is not done in all patients at risk, and reminds us all how important vaccination is. And if there is sort of a hole or a decline in the uptake of vaccination, then that's something which leads to immediate consequences. So really something I think we have to think of. Hepatitis B vaccine coverage worldwide, and this is from the WHO report, most recently from the EASL conference, tells you that we're doing a pretty good job at this point, 84% coverage, but you can see that in some regions, like Southeast Asia, which have a high hepatitis B prevalence, still the uptake is low, and so there's still, I think, improvement, but clearly with these vaccines in place being highly efficacious, clearly we have to use them and be reminded. The situation around Birthdose hepatitis B vaccination is dismal, and if there was a message from the pre-conference in Durban at the World AIDS Conference, the hepatitis co-infection conference, really was the demand for birth date vaccination, because that can prevent hepatitis B, and obviously in a country with a very high burden as Africa, this is a mandatory, and I think this is something we really need to fight for in the hepatitis field. Looking at the proportion of unsafe injections by regions, clearly challenges remain, particularly in the Eastern Mediterranean region. You can see how high the proportion of reuse is, and I think this just relates to one of the issues when we look at ambitious elimination programs like in Georgia. Nothing will change if there's not also a change in drug policies. There's no way you can successfully implement elimination programs if you do not also have sort of an atmosphere and a political and law environment which does not lead to immediate imprisonment in the setting of drug use, because obviously in the prison setting there is drug use. If there's no access to clean syringes, there will be reuse, and obviously that will all fuel epidemics. So many of these programs, I think, are crucially dependent on a change in the way we deal with IV drug users, and it goes without saying that criminalization kills, and I think you're also very well aware that there are many countries in the world where there is an ongoing criminalization of IV drug users. Even worse, that there is now a criminalization of other groups according to sexual orientation, and I think we are in a world which is changing in many ways very unfavorably for all these ambitious programs. Harm reduction also includes needle syringe distribution, and you can see that that has been achieved to a certain amount in the European region, much less in other regions, but even 27 needle and syringes per year is clearly not sufficient to satisfy the need of an IV drug user, and so I think we're really way behind, and if we really believe in elimination, this is something which has to come along. There is no way elimination will happen without harm reduction, and it makes absolutely no sense to distribute expensive drugs without thinking of other modalities of intervening in this system. That needle and syringe programs and opioid substitution work has been shown in numerous studies. This is just one example. I think the importance of this particular study is that it really shows that only the opioid substitution in combination with needle syringe programs is likely to have the highest impact on reducing the incidence of new infections. So it's really a combined effort of harm reduction interventions which needs to be highlighted. Opioid substitution, again, is not happening in many places in the world. You see here in the African map, in most countries we don't even know whether this exists or not. And in many countries, unfortunately, no opioid substitution is available. And obviously, if treatment is to be rolled out and in order to minimize risk of reinfections, it will be extremely important that these things get implemented as well. Looking at the cascade of care, I think it becomes evident that we're very far away from the ambitious targets the WHO has introduced into the field. Only 9% of the 257 million diagnosed with hepatitis B have been diagnosed. Only 1.7 million are currently on treatment. So this is dismal in consideration of the effective hepatitis B treatments we have, which can be produced on a generic level extremely cheaply. And it is really a disaster that many patients, in particular in Africa, are without hepatitis B therapy. And if you have the opportunity of visiting an African hospital, you see many patients with decompensated liver disease where even at that stage, administration of a nucleoside could be very beneficial. If they don't have HIV, they have absolutely no access to these therapies. So it's really kind of one of the weirdest things, I think, in the African setting, that actually patients with monoinfection are treated much worse than patients who have HIV, who at least then have access to some drugs. Cascade of care for hepatitis C is a little bit better with regard to the diagnosis rate. It's 20% of 71 million diagnosed, and I think that is at least positive news in the sense of the increase. There was an editorial by Dave Thomas in, I think, JAMA, like 10 years ago or so, where he said it was like less than 1% of the world population were diagnosed. So that has really considerably increased, and I think it is a function of the possibility of curing patients with hepatitis C has been a strong incentive. And I think just in parallel to HIV, if you remember when HIV testing made its way into Africa, there was very little uptake of HIV testing initially when there was no therapeutic intervention which was associated with a positive test result. And only in the availability of HIV therapy, testing rates increased substantially because patients suddenly realized that they then, if tested positive, would receive treatment, and that would have an impact on their further outcome. You see here that 1.1 million have started treatment in 2015. So although the diagnosis rates are going up, obviously the amount of people receiving treatment still is extremely low. And Andre Rauch, in his wonderful plenary at the Glasgow conference just a little while ago, compared the cascade of care between hepatitis C and HIV for several countries, for Australia, USA, UK, and Switzerland, so all countries with a relatively, let's say, extensive healthcare system. Also, particularly if you think of Switzerland, where obviously with all the wonderful money which is hiding in the banks, they have quite some resources. You can see that still, even in those countries, the amount of people who are treated is so much less than in comparison to HIV. So it tells us really that in the setting of viral hepatitis, we have a long way to go, and it's really quite appalling to see how many people are still left behind in comparison to the HIV successes. You heard the very nice talk by Nicholas looking at the hepatitis C elimination program. We discussed some of the challenges of finding the patients, and although I agree that the prevalence appears to be declining impressively, I think everything will depend on the subsequent screening strategies, because as Bart rightly pointed out, you almost need to screen everyone in order to achieve that further decline. And I think that will be one of the major challenges in the country, to identify everyone who has been at risk or who has hepatitis C and to get them included into the program. So I think a lot of the elimination programs will be challenged by sort of a great success in getting the first patients enrolled, but the question then becomes, how are you going to reach the other ones and get them linked to care? And I think one of the major things, because when the Georgian data is presented, a lot of countries are sighing and say, well, but they have the drug for free, and that's a different situation, and how's that's not necessarily for us. But I think one of the major messages for me is in the last 3 years where we have been organizing the IS Hepatitis Pre-Conferences. When we had our first conference, it was all about no one has the drug and the access and how difficult that all is. But what we've subsequently seen is that the uptake of DA therapy has occurred much faster in many regions of the world, which you would have never expected it. In Egypt, over 1 million people already have been treated. Just imagine what that means structurally, infrastructurally, to get 1 million people into care and to deliver therapy, prevent abuse and reselling of drugs, making sure the right patient gets the medication. And all of that has happened in the setting of an extreme and I think unanticipated decline in the price of the medication. And in the very nice Egyptian symposium at EASL, where they reported back on the outcome of their massive hepatitis C treatment program, there was a list of prices presented for the Egyptian region. And I thought it was of note that the generic formulation of sofosbuvir is available, and we're talking here of the 12-month package, is $25, and the decladisvir, which is a generic formulation available as well, is $3. So you have a $28 hepatitis C regimen. That is not that much. $28 for a cure of a disease appears sort of a kind of cost-effective treatment price. And it tells us that really it's not necessarily the price, it's really the will, and I think that's what we can learn from the Georgian region. It's everyone unifying for one goal. If the government and the other stakeholders in the country are willing to go down that route, I think then there is a way. And I think Europe is a very interesting example of how different the distribution of hepatitis C therapy is occurring depending on your reimbursement system. So if you live in Germany, you just make your price and the people pay, and that's all fine because Germany doesn't really worry so much about that. If you're in other countries, they say we have a much higher prevalence of hepatitis C. We're never going to be able to pay the German prices, and there is a long period of price negotiation. The Italians have negotiated sometimes over a year until they found their price. But in the end, by using models of prescribing by volume, so the higher the amount of prescriptions is, the lower the price becomes, they successfully have now achieved prices which are a tenfold lower than the German prices. So really telling you that depending on the political will and the force of which people are negotiating, you can arrange wonderful price scenarios. So I think price is not necessarily the barrier for access. It's really getting all people unified to fight and demand access. I think the patient organizations in Portugal have also played an important role in getting politicians motivated to enter their program. So it's possible. It's not happening only in the richest country in the world. Hepatitis C therapy is happening in many places of the world, even in very poor places of the world, but not necessarily everywhere. And so it's really a function of getting people together and mobilized and getting that energy to fight for payable hepatitis C combinations. In the end, I think a public health approach needs to deliver to all, including specific groups, healthcare workers, persons who inject drugs, indigenous population, prisoners, migrant, blood donors, men who have sex with men. In a century of changes, of a lot of issues in many different ways, and an increasing stigma and discrimination of vulnerable groups, I think this has become one of the biggest challenges altogether. Gay men are now incarcerated in concentration camps in specific Central European countries, and it tells us that there is a difficult way, because obviously if political or imprisonment or harm to persons is the consequence of sexual orientation, it's of no surprise that these people will sort of disappear and will no longer be reachable. So I think for all of the things we want to do in this world, we have to make sure that the vulnerable patient populations at least get protected. Looking at the global elimination strategies, on their way from 2015 to the sort of outlined targets for 2030, you can see that probably hepatitis B vaccination is among those with the highest probability, as well as blood safety. But you can see that with regard to harm reduction, diagnosis for viral hepatitis, as well as treatment, we have a very long way to go, and this will really need a combined effort in many different ways. At this meeting, we heard an excellent talk on hepatitis B cure. And I think although it is very basic at this point, I think we do realize that many drugs are in development at many different points of the replication cycle, clearly allowing intervention. I think all of the things which have been shown so far are showing modest effects. Clearly, it looks as if a combination of many different interventions seems to be the most feasible strategy, and obviously this will take a lot of time and a lot of clinical trials, but clearly an exciting area of research which will remain a challenge in the field of viral hepatitis. For hepatitis C, I think you see increasingly editorials like this one from Maria Buti and Alessandro Agemo in gastroenterology, which sort of accompany the published results of the Gilead 3-drug triplet, Sofvel and Vox, where patients who failed previous therapies are now also rescuable with this 3-drug regimen, and basically say the hepatitis C therapy, game over. We have so many drugs which can really cure every challenging patient population. So is there anything left in hepatitis C drug development to worry about? Well, I think we're still looking for a treatment indication for early hepatitis C infection, that what we considered or called former acute hepatitis C in the label. I think for many areas of the world, treatment of acute hepatitis C is challenging because of the fear of not having reimbursement for hepatitis C therapy. So clearly, having a large enough trial in acute hepatitis C leading to a registrational change and inclusion of treatment of acute hepatitis C, or better, maybe early hepatitis C in the label, I think would be helpful. In order to address the issues of the large number of undiagnosed people, clearly also if you think of rollout of therapy in Asia and in Africa, we need improved and simplified diagnostics, which are much cheaper. I think the barrier of current hepatitis C and B diagnostic, in particular when you do viral loads, is tremendous. So clearly we need new markers. First, in the context of the hepatitis B cure agenda, because we have no good markers which show early changes in cDNA levels, for example. Dry blood spot testing, I think, will help to increase the number of testing. So you can imagine that you can reach community members much better by easier testing facilities, also include community itself as a source for testing. And so the use of simplified tests, I think, will be essential in the rollout of hepatitis C therapy globally. There is also a need for more reliable diagnostic tests for hepatitis E. In the pre-course, you heard a very nice overview from Ken Sherman on the challenges of diagnosing hepatitis E. And remember the patient case he presented who died, and the positive result of the hepatitis E infection came like 10 days after the patient passed away. It tells us that there are limitations in hepatitis E diagnosis, and the differentiation between past and ongoing infection is also obviously important. And then I think in the context of hepatitis C, we saw a lot of data from FibroScan studies evaluating fibrosis regression. We saw some studies presented by Maren Peters in her overview on the impact of SVR on clinical outcome events. But I think in the end, we will need much more cohort studies which will study the impact of SVR on the further development of liver disease manifestation as well as non-hepatic clinical events. And I think that is not only important in context of the before-mentioned Cochrane analysis, which shows no benefit clinically for the SVR induced by DA therapy, but also for enabling and facilitating the uptake of DA therapies globally in order to have a stronger argument to really show what is the long-term benefit. And I think in HIV, this happened very early because a lot of the things we only learned through cohort analysis. Similar cohorts are not equally present and available in the context of hepatitis C, although many of them are in the process of being generated, and I think we really need that data. So clearly the diagnosis of hepatitis, in particular B and C, remains, I think, the biggest challenge. It is different from country to country because different patient populations are affected, but I still think there needs to be a lot of sharing of information to identify what is the best strategy, also from a cost-effectiveness point in various countries. The issue that HCV increases cardiovascular risk is by now, I think, well established. Hepatitis C has impact on lipid metabolism, can induce insulin resistance, cause diabetes, and clearly contribute to fibrosis and inflammation. And so in many studies independently, an increased cardiovascular risk has been shown as a consequence of long-standing hepatitis C infection. And first cohort analysis, I think, are nicely sort of showing the benefit of SVR, and I think more importantly, this is also now being demonstrated in low fibrosis stages, because most of the initial work was all around patients with cirrhosis, showing they have less liver cancer, less probability of dying from liver disease, and then eventually also showed an overall survival benefit. But that was restricted to patients with advanced liver disease, and what you're seeing now, and this is from EASL, from the French groups, showing that even in patients with F0, F1 fibrosis, in the long term, you have a survival benefit after achieving SVR. And I think that's important. That's the kind of data we need to convince payers why treatment of hepatitis C is essential. And this is a further interesting study looking at compensated hepatitis C-related cirrhotic patients who, after achieving SVR, show a much lower incidence. It's a 65% lower incidence of major cardiovascular events. And so I think that sort of all goes in the right direction, sort of getting data to make sure and clear that the benefits of hepatitis C therapy go way beyond the improvement of liver disease, but really also target extrahepatic manifestations. With regard to hepatitis C diagnostics, the core antigen is clearly one of the more promising tests, as it allows a simplified treatment monitoring and is easy to perform, much cheaper, and will allow, I think, help the rollout of hepatitis C therapy in some of the regions where PCR technology is not easily or readily available. In Vincent's very nice overview of Delta infection, he introduced the various achievements in the therapeutic arena, and I think for a long time we haven't heard very much, and for the first time we've now saw several studies looking at new therapeutics for Delta infection, which are obviously eagerly awaited. The outcome of Delta infection still remains very dismal, and clearly Merck B as well as norepinephrine show at least some promise, and so I think we'll see how these drugs perform and continue to follow up and further trials. And finally, there is still an ongoing discussion about the need of a hepatitis C vaccine. I think in the end of the day, many viral infections are best controlled by a successful vaccination, and clearly there are still, although there are few, there still are some groups which are working on hepatitis C vaccine development. I think that area of research still needs to be encouraged and carried forward. So in summary, I see a need for increasing hepatitis A and B vaccination rates. Diseases which you kind of forget about, like hepatitis A, may reemerge, particularly in the prevalence of low vaccination uptake rates. We have to fight for an increase in HPV birth vaccination in the context of the African continent, where that is still not happening in more than 20% of newborn babies. I think there is a global quest to increase access to harm reduction interventions, because in the end of the day, we have so much data which shows us that opioid substitution in combination with needle syringe programs has so successfully changed epidemics and decreased successfully incidence of new hepatitis C infections. It just makes sense to have that everywhere, and we have to continue our fight in political systems which are rigid and against these interventions. Of note, only 9% of all HPV infections and 20% of all hepatitis C infections globally have been diagnosed up to now, so clearly there is room for improvement. Treatment coverage remains dismal, with only 1% for hepatitis B and less than 10% for hepatitis C, and that in the face of drugs which successfully treat and cure these infections is, I think, still really appalling. We need to develop simplified diagnostics for viral hepatitis. It's the only way to get access to therapies in parts of the world where regular PCR and genotyping will simply not be possible. Clearly, the quest for developing new hepatitis D drugs remains. We have to invest in the hepatitis B cure agenda and continue to develop a hepatitis C vaccine. So I'll close here, and thank you for your attention.